Welcome everyone to the eMedica MRCGP SCA Essentials webinar. We're running this webinar in conjunction with the Medical Protection Society. So for those who haven't met me before, a brief introduction. My name is Muhibbur Rahman. I'm a portfolio GP and a medical director of eMedica. So portfolio GP is a GP with multiple roles. So in terms of clinical, I'm a partner in my own practice. I cover 2 community detox units. So actually had like 2 patients that I admitted in 2 different units yesterday. I've been in clinic this morning. And then most of my time now is teaching and preparing courses for eMedica, but I also work as a consultant in medical education. I advise people like the MPS, work with various organizations. We've helped to develop assessments for organizations training people. So, with deaneries, we've run courses jointly with RCGP faculties. We've prepared some learning materials for actually people doing family medicine residency outside of the UK as well. I did recorded consultations as part of the old MRCGP, and we had an exam called summative assessment in our 3rd year of training. But I also was involved in piloting the CSA and sat the very first sitting of the actual CSA in September 2007, passed every case and was awarded it with merit. I've been writing and teaching about MRCGP now for nearly 20 years. I wrote the MPS MRCGP study guide and more recently the SCA study guide, which is due to be published in the next couple of months. And we ran CSA preparation courses for over 12 years. And then when they switched to RCA, we ran RCA courses for as long as RCA was running. And we've been running SCA courses since before the first SCA sitting. And our team have trained over 77,000 delegates now. So let's get into what we're going to cover today. I'm going to start with an overview of the MRCGP SCA, the exam format, the schedule. We'll look at how the exam is marked. What type of cases are you going to get? Then we're going to look at why do candidates fail? We've got several exams worth of data now. And then we'll look at the habits of those that don't just pass, but really smash the exam. The people that get really, really high scores, because again, we've had quite a few of those candidates and I've asked them for their tips. I've done some interviews with some of them. So we can look at why do people struggle? How can you avoid that? What are the things that people that do really well have done? And maybe you can emulate some of those things. And that will finish with, how to prepare for SCA, including we'll talk about the resources that eMedica offer if you want our support to help with SCA. I'll then look at frequently asked questions, and then any questions not covered in that, there'll be a dedicated Q&A at the end. Okay, so that's the plan. Let's get into it, shall we? So let's start with the exam. So SCA stands for Simulated Consultation Assessment. It's a relatively new assessment. It was only launched November 2023. So we haven't even had a full year or even a full academic year's worth of exams yet. You can only sit this in the ST3 year or later. And for people who are already in training at the time the exam launched, there's a maximum of 4 attempts. So there's a 5th attempt possible only in exceptional circumstances. So, someone that, for example, passed the AKT, was doing well with workplace-based assessment, if they needed a 5th attempt, that would be possible. And some of you might have already been in training and done RCA, and then it switched to SCA. Your RCA attempts count towards this maximum of 4. Now, if you're in ST2 or ST3, this is what applies to you. If there's someone that's here really early, if you started training August 2023 or later, the new regulations allow for 6 attempts, okay? The exam fee is £1,180. So in terms of the format, it's basically a simulated surgery. So you're going to do 12 consultations, each lasting 12 minutes with professional simulators. There's a 3-minute gap between cases, so you can read the notes. And then basically they come on screen. You've got 12 minutes exactly, and then they disappear. It's not like a second extra. It just goes blank, and the notes come up for the next case. You get a 10-minute break halfway. So after 6 cases, you get a 10-minute break. And the exam's available. There's a morning session and an afternoon session each day it runs. You'll do it remotely generally in your training practice. In a very small number of cases, if your training practice has issues with the connectivity, if they don't have the certain internet speed, for example, you might do it in a local practice within your area. Okay, but you're not going to go to the RCGP building. You'll do this remotely from either your practice or one local to you. And the exam is a mixture of remote video consultations and remote telephone consultations. So you're not going to see anyone face to face because the whole thing's remote. And generally the proportion is 9 remote video, 3 remote telephone. Okay, that's the proportion. You may get the odd sitting on the odd day where that varies maybe by one. So, you might have 8 video and 4 telephone, for example, but that's the general proportion. And the whole thing's recorded and then marked later by RCGP examiners. So it's not marked at all while it's happening. There's no live marking of this exam. And it's available 9 times a year. So, if you think about the academic year starting, people start ST3 generally in August, right? Well, it's available September through to June. There's no December exam, and then they have a summer break for July and August. So that's why it's 9 times a year. If I show you a schedule, for example, this is what's available on the RCGP website at the moment. So we've got what's left this year. The June exams happened. The results aren't out yet. They're going to come out at the end of this month. We've got the September, October, and November. There won't be a December exam, and they haven't announced dates yet for January 2025 onward. But just useful for you to have a look at those dates. Generally, it happens in the early part of the month. And then what happens is you can generally reserve an exam slot, like as in a month, up to 12 months before. So when you start ST3, for example, or even before you start ST3, once they announce the later dates, some of you might already be thinking about the September sitting. You've got to reserve by the 7th of July. If you haven't reserved, when the booking period opens, which is 15th to 19th of July, anyone that hasn't got a reservation, they will not be allowed to book. And that's for a September exam. They've said to be confirmed in terms of the results, but generally the results come out at the end of the month that the exam happens. A few months, like in May, because there were so many people that sat it, they were delayed by a week. It came out the first week of June. Similarly, April, it's a big cohort. The results came out the first week of May rather than the end of April. But generally, so within about 4 weeks, you get the results, 3 to 4 weeks. Okay. So what are they looking for? A good way to look at SCA, it's GP finals. They're looking for someone who's ready to practice as an independent GP safely without needing supervision anymore. So the standard that they're testing against is a standard for a fully qualified GP to practice without any support, without any supervision. Okay. Within that, what they're looking for is, can you keep patients safe? So part of that is when you're taking a history that you think about not just how do I get to the bottom of what's going on here, narrow down your differential, but that you exclude less common but more dangerous things by asking the relevant red flags. That you keep them safe when you're thinking about prescribing, doing things like as part of your management, thinking about safety netting. That you're adaptable in treating different types of patients and illnesses. So every sitting of the SCA, there's going to be a range of case types across the curriculum. I'll show you the blueprint in a minute. That you can manage risk, but you can also manage more complex cases where some patients might have multiple things or a main thing that they're presenting with, but they've got a background risk that also needs to be taken into mind. There might be social and psychological aspects that make the clinical thing more complex and uncertainty. And that you can demonstrate appropriate behaviors, attitudes, that you're person-centered in your approach with patients, but also one of your cases might be with a colleague rather than with a patient. So they mark each case in 3 domains and they're marked separately. So data gathering and diagnosis, i.e., can you take a concise, focused history? Can you sort of explore the relevant risk factors? Can you exclude the relevant red flags? Can you put all of the symptoms together to come up with the right diagnosis, or at least narrow it down to a sensible differential? You'll notice that diagnosis is part of the data gathering domain. It's lumped in together. This is a big change from both SCA and RCA, where diagnosis was part of the management domain. That's a significant change. The most important domain in terms of marks is clinical management and medical complexity. That's because this domain has 50% extra weight compared to the other 2. So whatever your score is in management, that gets multiplied by 1.5. They're given this more weighting. And then relating to others. So this is about interpersonal skills, about being person-centered. It's about your effective use of language, picking up on cues and exploring them, exploring and integrating the social and psychological aspects. Okay, management, is your management up to date according to current guidelines? Is it safe? Can you deal with follow-up appropriately, safety netting appropriately? Can you deal with other risks? Do you recognize that some things might need a follow-up appointment? And what they have is for each of these domains, and they're marked separately. Let's look. Someone could take a perfect history and get the diagnosis right. But they took so long, and they might get a clear pass for that, but they did so long to take that, they actually just didn't have time to discuss management. They could get a clear fail for management. And they're relating to others might be good, but there might be some things that aren't quite there. So they might get a pass for that rather than a clear pass. So they're each marked separately. And then your marks get converted into scores, which we'll look at in a minute. And so they have sort of generic descriptors for each of these three domains in terms of what are they looking for. But then each case has a specific mark scheme, specific things that they're looking for in the history and diagnosis, specific things in the management for that particular case, specific things in the relating to others for that particular case. If I show you the generic markers, data gathering and diagnosis, that you're systematic in how you gather and organize your data, and that you're targeted. You've got limited time, right? Your 12 minutes is for everything. You can't spend the whole 12 minutes just taking history. All right. And so can you do it in a targeted way, asking the relevant things, focused? If like a bit like a house officer, they ask about everything. If you do that, you're just never going to finish. You get a clear fail for every case because for the management, because you're just never going to get to management. You see, if you don't get to that domain, you automatically get no marks for it. That you're structured and you sort of take on board what the patient's saying to have an informed approach to working out what's going on, to get an appropriate differential. And where it's something where you don't have background information or it's complex, that you can use first principles to at least narrow it down to a sensible differential. I.e., you can ask the right questions in an appropriate way, take on board what they say, ask the right follow-ons to work out what's going on, to solve the problem, to make the diagnosis. Clinical management and complexity, that you can have a safe and appropriate management plan, that you also think about managing your time, self-management for the patient, what are things that they can do, and that you're also thinking about managing the immediate problem, but long-term issues. That's where the complexity comes in sometimes. And relating to others, really, this is about, ethics, about communication skills, being person-centered, being able to sort of deal with some patients might have, for example, a learning difficulty or a hearing problem, or, there might be additional challenges to communication. So can you adapt to those things? And for each of the domains, you get graded clear pass, pass, fail, or clear fail. So a clear pass is worth 3 marks as a raw score. To get a clear pass, what you've demonstrated for that domain would be deemed excellent for a fully qualified GP. Are you significantly above the standard needed to just qualify? A pass is worth 2 marks. To get a pass, what you've demonstrated has to be deemed competent for someone fully qualified to practice without a supervisor. A fail is worth 1 mark. It means you're below the standard for a fully qualified GP. Now, sometimes the difference, for example, in data gathering and diagnosis between a pass and a fail might be someone that didn't ask an important red flag. Do you see? That's below the standard of a fully qualified GP. Would expect them to exclude that, then that would be a fail. All right. A clear fail is worth no marks for that domain. And it means that what you've done is you've done something that's really unsafe, or you're below the standard in multiple areas in that domain. I'll give an example. For data gathering and diagnosis, someone that missed important things in the data gathering and got the diagnosis wrong, that would be a clear fail for data gathering and diagnosis. Okay. Clinical management and complexity, someone that proposed a management but didn't pick up that the patient had a contraindication to that treatment, and so it could actually be really harmful to that patient, that would be a clear fail for management. Or someone that just didn't, they were still taking history and talking about and explaining the diagnosis. They knew the management, but they just never got to discuss management at all. That's automatically a clear fail for that domain, because they can only mark what you've demonstrated. They can't give you marks for what they think you would do if you had a few extra minutes. Okay. Now, alongside that, so this determines your score, right? So, for example, someone that did really well and got a clear pass for data gathering and diagnosis, a clear pass for management and complexity, and a clear pass for relating to others. They get clear pass, clear pass, clear pass. Okay, so their raw score would be 9, 3, 3, 3. But remember that management and complexity is weighted 50% extra. So a clear pass in management actually is worth 4.5 marks because they multiply the score by 1.5. A pass is worth 2 if it's for data gathering and diagnosis or for relating to others. But if it's for management, they multiply by 1.5. So it becomes 3 marks. Okay. Now, for any cases where you get a fail or clear fail for any of the domains, there are 25 feedback statements. So the examiners might give you feedback to say, look, within the data gathering and diagnosis, let's say you got a fail. They might give you a tick for some of the feedback statements relating to data gathering and diagnosis. So it might be, for example, that they tick that you were disorganized in your approach to history taking, or that your history taking missed important things like the red flags, and so that you can look at that and say, okay, that's why I got a fail, and so you can use that to improve. The feedback statements, you'll also know which case did it relate to, right? And remember, the whole thing's recorded, but then it gets marked later by 12 different examiners. So each of your 12 cases will be given to a different examiner. Each examiner is only marking one case for each candidate. So you will be assessed by 12 different examiners in total. So if we look at the pass rates and the pass standard, the total number of marks for the domains are, remember, 12 cases, maximum 3 marks for each case in data gathering. So 36 marks in total for data gathering and diagnosis, 54 marks for clinical management and medical complexity, because that's weighted 50% extra, and 36 for relating to others. So in total, it's at 126. And they adjust the pass mark based on how hard were the cases on that day. So the pass mark can be different on different days, because some days the cases are more difficult than others. So far, the pass mark has been either 76 out of 126 or 77 out of 126. So it hasn't changed that much, okay? But it can change. And it's possible, theoretically, that on some days it could go up a bit more. It could be 78 out of 126, for example. And if we look at the pass rate, the RCGP only actually published data on sittings up to March. So we've got data from the November sitting, from the January, the February and March. Although we've had the results for April and May, they haven't published the summary report, which they normally publish a few weeks after, but they haven't published that yet. Both of those are delayed. So far, I've analyzed all the data that we've got so far, and the pass rate has been as low as 66%. For the first few sittings, November was around 66%, and the highest was the March sitting, 72%. The mean, I added up all the people that have sat it and how many have passed from the data that's published so far, is 68.9%. So you can see, it's got a significant fail rate. You've got to take it seriously. So more than 3 out of 10 people, nearly a third of candidates are failing. Okay. You can look at it the other way. That, look, 2/3 of candidates and slightly more than 2/3 are passing. Okay. And in terms of the cases, in each exam sitting, in each day that the exam is sat, the cases are completely different to the case on the next day. All right. So within a given sitting, each day the cases are different, but each palette, so like each day of cases, they will make sure that you get exposed to cases across 12 case domains. So you'll have at least one, which is a child health case, so someone under 19. One that will be gender, reproductive, and sexual health. So that could include women's health issues, men's health issues, LGBTQ plus, gynae, breast, all of those would fall within that one. You'll get one which is a long-term condition, and that could include cancer, someone with multiple chronic diseases, diabetes, heart disease, hypertension, disability. Older adults, including someone near the end of life or frailty, mental health, and that could include, classical mental health, if you like, depression, psychosis, OCD, but also include things like addiction, substance misuse, alcohol addiction, urgent and unscheduled care. So, someone that might need an urgent referral or an admission. Health disadvantage and vulnerability. So that could include someone who's ex-military, veteran, someone with issues around mental capacity, maybe dementia, safeguarding, and communication difficulties. So maybe a learning difficulty, maybe someone with hearing issues, ethnicity, culture, diversity, inclusivity. At least one will be a new presentation of undifferentiated disease. So someone that's never presented with this illness before. It's completely new. First time they're coming with it. Prescribing, understanding investigations, interpreting results appropriately. And the number 12 is a bit different. A professional conversation or professional dilemma. So this might be a case where rather than a patient, it's a colleague that you're having a discussion with. Remember, they're all simulated, but this one's a bit different. So it could be like a practice manager, or it won't be another doctor, but it could be someone else that might be working with you in the GP setting. Okay. Pharmacist, receptionist, secretary. Okay. Now, there are some cases that will span curriculum areas. You can see you could have a child health, so let's say a 15-year-old come to speak to you about getting contraception. So that fits with gender, reproductive, and sexual health. Okay. But then there might be an element of prescribing there if you give them the contraception that they request because you deem them to be suitable to have it. But then there could also be a safeguarding issue. Do you see? So one case can span different things, but throughout the whole exam, they want to make sure they've assessed all 12 of these. Okay. In terms of the kinds of cases that you might get, think about the things that you could see every day in a clinic. You won't get any cases that are absolutely straightforward. So when the RCA was running, they used to have cases that they deemed low challenge, and people that submitted low challenge cases, one of the things is that they would typically lose marks because they were too simple. And because they're setting the level of challenge, they don't have any cases that would have been deemed low challenge in the RCA. They don't have those. So you'll have some cases that are of medium challenge, but you'll have some that are really tough, where there may be complexity. But in terms of what it could be anything that we could see in GP. So that could include everyday stuff, but also some of the less common, more serious things that they want to make sure you don't miss. And you could have some cases that have more than one thing that they're presenting to discuss with, just like we have in real life. That adds a level of complexity. But I'll give you some examples. So you could have, a patient who's diabetic, and they've come for a diabetic annual review. But while you're having that review, they seem a little bit down, and you sort of pick up that maybe there's something going on with their mood there. And so do you see that could span the mental health domain and the long-term condition domain? You could have an example of someone who has booked an appointment, and the reason that they booked an appointment is that recently their father had a heart attack. They got really scared about their own risks. So they came in and they'd been called for an NHS health check because they're 40 plus, but they've never come. But because of that, they decided, look, I'm going to come in and get tested. They had their blood pressure, they had all their bloods done, and you're presented with a follow-up, and they've got all their results, and for you to interpret the Q risk and discuss where we go from there and look at the lifestyle issues and what they can change because you already know their genetic risk and you already know their Q risk. A patient who's a teenager and you suspect an eating disorder, maybe they've got anorexia. You can see that spans multiple domains. You've got mental health, patient under 19, new presentation of undifferentiated illness. They've not ever been seen before about suspected eating disorders or about this issue. Someone who's been tired all the time for 3 months or longer than 3 months. Now, you can see there's lots of things that could cause someone to feel tired all the time. You've got the common things: diabetes, anemia, depression, vitamin D deficiency, thyroid problems. Someone with hypothyroid can feel really tired, right? But you could also got less common, more serious things. Someone could feel tired, fatigued. It could be a sign of a malignancy, couldn't it? So, but again, this patient's never been seen about tiredness or fatigue before. And so it's an example of a new presentation of undifferentiated illness. Depending on what you find, it might also span into urgent and unscheduled, because if you think the cause of their tiredness could be a red flag for a cancer, suddenly it becomes an urgent in terms of, you're going to arrange for them to be referred for a suspected cancer, right? So you can see a full range of the kinds of things that we might see in GP. So give an example of the information that you're going to get, okay? So you have 3 minutes reading before each case, and it's all on screen. After the 3 minutes, the notes disappear, but they're still available. So the patient comes on, they sort of fill the main window in the screen, but then there's a little button you can click if you want access to the notes again to bring them back up, okay? And it will state, is this going to be a video consult or is it going to be a telephone consult? But it won't state what the case domain is. So it won't state that, this is a patient that, is come to talk about gender, for example, or that it's going to be a urgent, unscheduled. You won't know that. That's for you to work out, okay? You will be given the core details, so name, age, and then there might be past medical history, recent consultations, maybe a letter from clinic, discharge summary if they've been in hospital, blood results, other types of results or images, recent examination findings that might be relevant, because you can't physically examine any of these patients, but sometimes there might be some relevant findings, or sometimes they'll give you a recent clinic where they had some examination so that you can use that information. Okay, so if I show you, it could look something like this. So it could be a screen. It could be even less. It could be someone who's a temporary resident or a new patient, and you've got actually hardly anything. It could be really detailed. It could include an image. This is one from one of the example cases on the RCGP website. And then it could be as much as 3 screens worth of information, and you've got 3 minutes to read it. So some candidates have mentioned that they had to scroll down, screen 1, screen 2, screen 3 to get all that information. So you've got 3 minutes to read that. Then the patient comes in, then you do your consultation, and after 12 minutes is up, it just goes blank, and the next set of notes comes in, and there's a little 3-minute timer so that the next notes come on. When the patient comes on screen, or if it's a telephone one, you just hear the patient, okay? A 12-minute timer starts counting down, and that's visible throughout your consultation. So it counts down from 12 minutes down to 00, and then goes blank. The notes then come on, okay? You do 6, you have a 10-minute break, you come back and you do the next 6, okay? If there's a technical issue, so sometimes it might be that you can't hear, it is being invigilated. So there's no examiner marking, but there's one person that's invigilating lots of exams going on. So for example, if there's an issue, they'll monitor, yeah, there's a problem at the end of the simulator. That case, half of it you couldn't hear. There is an opportunity at the end of each exam session to replay 1 or 2 cases if necessary, okay, if there's a technical issue. So let's talk about how to prepare for the exam. Why might people struggle, and why have people struggled? Because we've had, enough sets of results now to see some of the common patterns in people that we've helped when they're resitting and analyzing their feedback. And then we've also had enough people that have done really, really well to see some of the habits of the high performers. Okay, so how to prepare? Well, first thing is that, your exam cases are each going to be exactly 12 minutes, not a second longer. So getting comfortable with about 12-minute consults. If you're on 15 minutes in real life, that's okay, because in real life, remember, in a lot of cases, you're going to need to examine, and you also need time to document the notes. You're not going to be doing that. You're not going to examine anyone. You're not going to need to document the records. So if you're on 15 minutes, and that might be okay. When you're practicing with your colleagues, though, you should practice to exactly 12 minutes. When you're practicing mock SCA cases, exactly 12 minutes, you get used to that exam timing. But in real life, if you can cope with 15 minutes, that probably means you're, getting towards a point that you might think about sitting an exam. If you're still on 20-minute appointments, and even then you're struggling, you just give yourself time. You don't want to put yourself in a position, because someone who's consulting at that pace, you can't suddenly change your pace for the exam. And if you're struggling with 20-minute consults in real life, or 15 minutes, you always run over. You're not comfortable with 15. When it's suddenly 12 minutes, you'll find a lot of times you're going to not have time to do your management. So it can significantly impact your mark, because that domain is worth more than the other 2. So when you're practicing cases, have a timer. It's like a kitchen timer, okay? Set it to 12 minutes, okay? And do it exactly to time. Join a study group. And, if you're in a study group and you're regularly practicing, one of the things to make the most benefit is have, on a given day, 3 of you. One to be the doctor to have a go, one to be the simulator, the patient, one to be the examiner to observe, take notes during the consultation and give feedback afterwards, and to sort of agree that you're going to be honest about what someone needs to change to get better. Because sometimes what happens is when you're with your friends, you just focus on the things that are great, and that gives you a false sense of security. If you don't know what you need to change, how will you change it? Okay. Now, 3 is a good number to meet on a given day, but try to meet with different people on different days so you can benefit from their experience. Try to have as many observed consultations and as much feedback as possible. So do some joint surgeries where, you have your trainer or one of the other doctors who are experienced in your practice sit in and watch you, but do some the other way. Sitting in and watching someone consult who's got years of consulting experience, there's things that they will have picked up that you think, oh, I really like the way they did that. And you don't have to be, there's not one way to consult. You could take the best of what you like from this doctor's approach, the best of what you like from that doctor's approach, with whatever you're already comfortable with and you're doing well in your own approach, and you can incorporate it to get better. Try to record some consultations so that you can watch them back and you'll pick things up, because remember, these are going to be marked later based on a recording. So you'll pick things up. And if you can do those recordings with the same setup you're going to use in the exam, the same camera, the same microphone, you'll pick up technical issues like, oh, you know what, the sound quality is not good. I need to maybe have the microphone a bit closer, or not rely on the built-in microphone. Okay. Or actually, it's really blurred. Maybe we need to change the camera, or the angle is such that it's really difficult to see if I seem engaged. Okay. You know what? I need to look at I'm not making eye contact just because of the way the camera is positioned. If I'm talking like this, it looks like I'm not interested, right? I've got my camera such that I'm looking at the screen, it looks like I'm engaging, right? Okay, so things like this. And then, do as many role plays as you can. You could use tutorials with your trainer, ask them to be the patient, and then to give you feedback. You could, even in out of hours, have someone listen into one of your telephone consults. Remember, 3 of your consultations in your exam will be telephone consults. Some of those could be in an out of hours setting. You want to get comfortable in your own skin. Develop your own consulting style. If you suddenly trying to change everything that you're usually doing about your consulting 2 or 3 days before the exam, it will come across as really awkward because you're not comfortable with it. To change how you consult takes time, weeks, sometimes months, because you've developed that over years. It's not something you can change overnight. But it's important to understand that, there are some big myths about the SCA. So one of the biggest myths is that people that get in their head, this is primarily about communicating. And if you're just nice, you're going to pass. They set themselves up to fail because less than 30% of the marks are to do with communication and relating to others. This is primarily a clinical exam. Of course, good communication is an essential part of being a good GP. But can you see, if you look at the marks, I'll just go back to here. Look, out of 126 marks, 54 clinical management and medical complexity, and 36 data gathering and diagnosis. Only 36 for relating to others. So 71% of the marks are clinical. These 2 domains are clinical, aren't they? This is the one to do with communication. Less than 30% of the marks are to do with communication. And so you've got to really know your stuff inside out in terms of clinical knowledge to revise your core knowledge. Because if you manage it in a way that it might not harm the patient, but it doesn't fit the current guideline, that's not enough for a pass in management domain. It needs to be according to the current guidelines. So you need to be up to date. Similarly, if you don't know your guidelines, how are you going to make sure that if you're running short of time, that you make sure you don't miss anything essential in the history, the things that could change the diagnosis or change the management plan. So you need to revise your core knowledge, know your guidelines. You've also get comfortable with remote consultations because it's something that we're not doing that much day to day. Unlike during COVID, we were all doing almost all remote consultations in most surgeries. Most surgeries have gone back. That mostly we see people face to face. We do a few telephone consults, but some of those are more triage rather than full consults. We do very few remote video consultations. Yet your exam is going to be primarily remote video with a few remote telephone. So practicing something like that can be useful. Okay. So even in your study groups, doing it over Zoom or Teams or something like that. So because sometimes there are issues to do with that, some of the way that cues come across when someone's in front of you. That slight delay sometimes, that someone's talking and then you're talking, getting used to that takes a bit of time. And then if you can attend a course where you can practice cases with a simulator, who's a professionally trained actor, and get detailed individual feedback about what do you need to change from someone experienced, that can help you to get a different perspective from, say, your trainer who knows you. And sometimes they're observing you. And it's very useful to get feedback from them. But sometimes they're not going to mark you in the same way as an examiner who doesn't know you will mark you. So like in a given case, you might mess up a particular explanation, but they've seen you explain things really well 5, 6 other times. So they'll just say, your communication's fine. But the examiner will mark exactly what they saw in that case. And you might have got a fail for the relating to others domain in that particular case. You see? So getting a perspective from someone that doesn't work with you day to day, but also having simulators that will respond how the simulators will respond in the exam. Because again, when you practice, with a study group, sometimes what happens is who's being the patient will sometimes give the information too easily, sort of help you a little bit too much, which isn't going to happen in the exam. Or sometimes they're not sure how to give the cues or to display some of the emotions in the correct way. So while that's really helpful, it can be useful to get a different perspective, to work with real simulators and with someone experienced giving some feedback. So I've looked at the feedback from candidates who failed, who have requested help with a reset. I've done that for many candidates now. So looking at and analyzing some of the things that are common in terms of why might candidates fail. These are some of the trends that I've seen. So first one isn't to do with the feedback specifically, but it's more general things, that sitting it too early. Remember, the standard is not, is what you've done good for a registrar who's still got 6 months left or 9 months left? Or do you see, the standard is, if you're a fully qualified GP and the only doctor in the building that day, is what you've demonstrated in each of those domains safe? Does it demonstrate competence? That's pass. Does it demonstrate excellence? That's clear pass. Okay. And so, like, we wouldn't expect someone who's right at the beginning of ST3 to be practicing like a fully qualified GP. Some will be, but can see a bigger proportion won't be. And we sort of see that the pass rate for the first couple of cohorts, November, January, were lower than the later cohorts. People that sat it in March, they're sort of more than halfway through their ST3 year when they're sitting it if they started in August, right? People sitting it in November, if they started in August in ST3, they've only had a few months at ST3 level. We wouldn't expect them to already be practicing at that level, but that's the standard. They don't adjust the standard. They don't know. The examiners have no idea where are you in ST3. What they're marking against is the level of fully qualified GP. Similarly, you're much more likely to have got comfortable with managing time later on towards ST3 than right at the beginning of ST3. The most common domain that has impacted or caused someone to fail from those that I've analyzed so far, I'm waiting for them to publish like an annual report where I can get access to maybe several thousand cases worth of data, because I did that with the CSA, and that was really helpful. But from the ones I've seen so far, it's to do with management plans. Now, when I've actually talked to candidates, in some cases it is that they actually just didn't know the management, for that case. So that can happen. But in a lot of cases, they just highlighted that they spent too long on their history and they just didn't manage to finish management. And sometimes they just had actually only just started to talk about management and hadn't even finished the main management of the main problem, never mind follow-up and safety netting. If you haven't even completed the main management, that's going to be a clear fail for management domain. Okay. It's not enough that you know it. If you haven't actually demonstrated it, the examiner can't mark it, because they can only mark what they see in the recording. They're not allowed to give marks on what they think would happen, because then that wouldn't be objective. So sometimes it's because they've not had time. Sometimes it's that they don't, they get the management wrong. Sometimes it's, unsafe. Poor history taking skills. So common feedback statements that we see is being disorganized. So someone that sort of jumps around. They started taking a pain history. They don't finish the pain history. They jump to some social history. Then they jump back and get some more about the pain. Then they ask about a risk factor, and they ask about one red flag. Then they explore some social and psychological. And then they jump back and they finish another red flag. So it comes across a bit disorganized. They end up repeating some things. They end up losing time, missing things. So, in terms of poor history skills, disorganized or missing important red flags or missing important risk factors. Okay. Poor time management. So if you spend too long in the history, even if you know the management, you're not going to have time to actually deal with the management. And that has a big impact on your marks. Similarly, if you sort of spend too long on the history, what you might find is by the time you actually come up with a differential and explain the diagnosis, if you're saying a new diagnosis to a patient, in most cases, they're going to have questions, aren't they? They're going to ask things like, okay, well, can you treat it? Or how long will it take before I feel better? Or what's the next steps? Or do you see? So before you've actually got to the management, there may be questions to do with the diagnosis. Remember that diagnosis is part of the data gathering and diagnosis domain, not like getting the diagnosis right gives you no marks for management. So that can have an impact. Being doctor-centered. So sort of giving management plans in a way that as if the patient has no involvement or isn't offered the chance to share their opinion. Having poor active listening skills. So missing cues. This is really important because the way that the scripts work is that the actors will have a set line that they will give as the opening line. They'll have some information that they give freely, but they'll have some information which they'll only give if you ask a specific relevant question or if you explore a cue that they give earlier. So, like sometimes they might drop a cue that's really obvious. Okay. Doctor, I've been having some pain and I'm really worried about it. What's the cue there? The really obvious cue there is they've mentioned worry. Okay. So it would be logical to pick up on that cue. Sorry to hear that you're having pain. You said you're really worried about it. What is it that worries you? I'm really worried that it might be something serious. When you say something serious, there's something specific that you had in mind. Yeah, my dad had similar pains. And then suddenly one day, he had a massive stroke and he dropped dead. So I'm worried that these headaches could be actually like an early warning that I'm going to have the same thing that he had. Now, do you see what I mean? So that's a really obvious cue. But sometimes the cues might be more subtle. It might not even be the words. It might actually be the way it's said. So I'll give you an example. You ask a patient if they smoke and they say, I don't. Now, you could hear that just as I don't smoke, but that's not what they said. What did they say? I don't. The emphasis was on the I. What could we pick up from that? That's quite subtle. Could pick up, oh, you said you don't. Does someone else in the house smoke? Oh, yeah, actually, my partner smokes. And actually, it really bothers me because my son's been coughing a lot. But whenever I bring it up, it's actually causing issues in our relationship. He has a go at me. And then the other day, there was an incident. Oh, what was the incident? Well, we got into a real big argument and then he hit me. Wow. There could be something really big there that's come from exploring that cue and getting that bit more detail, right? Okay. Was someone that just heard that as I don't smoke rather than I don't and didn't follow up that cue, they would probably give you another cue that there's something else going on. But if you missed a cue a couple of times, you just might not find out something really important that could actually be the crux of the case. Do you see? So that's really, really important because if you miss some important cues, you might not get to the bottom of what's going on, which might mean you don't get the right diagnosis or differential, which then can have an impact that you're just not going to get to the right management. Do you see? So the one can lead on to the other. Poor sensitivity. So sometimes it's not what you say, but the way you say it. Not building rapport and poor communication skills. Okay, so these are some of the things that can lead to losing marks. But so far, the feedback that I've seen of people that haven't passed, in almost every case, the domain that had the biggest impact and why they ultimately was management. In a lot of cases, is both management and data gathering. Communication, the relating to others, is usually the one that's had the least impact in the people that I've seen issues. Okay, so what happens, if someone does fail? Really important to look through the feedback statements, the feedback that they give you, because they will give you how many cases you got marks in the data gathering, how many were clear fails, passes, clear passes for data gathering, how many for management and complexity, how many for relating to others. They'll give you a total score. They'll give you the feedback statements. Which of the 25 feedback statements? So there's feedback statements that are global about your overall consulting, some that are specific about data gathering and diagnosis, some that are specific about complexity and management, clinical management, some that are specific about relating to others. Which of those applied and were highlighted by how many different examiners in how many different cases, so you can work on them. It's really important that you change your approach. Get some extra support, get additional training, increase the number of observed consultations. If you didn't already get individual feedback, get some. If you got some, get more. And then don't rush to resit. Because one of the things is that this exam, imagine this is the pass standard. Someone that just fails because they rushed to sit it, they just failed by 1 or 2 marks. Sometimes what happens, it can really dent your confidence in your real life consulting and your preparation for your next exam. And then what you sometimes see, and actually I found this in a candidate very recently, last week, their first exam, they failed by 2 marks. The second sitting, they failed by more than 10. It went down. Why? Because their confidence was ruined. And if you then don't get the right feedback as to how and what you need to change, sometimes you try to change everything you know about consulting, including throwing out the good things that you're doing. Or sometimes people, they read a consultation model from a book. It's not at all how they're consulting. They don't know how to apply it and make it seem natural. They haven't practiced enough. And so they're just trying to like tick imaginary boxes. It comes across very robotic. They've got like a 15-point checklist. In 12 minutes, if you've got a 15-point checklist, that's like more than one thing every minute that you're distracted with. You miss what they're actually saying. You miss the cues, and then they end up struggling. Instead, you need to really get feedback on what it is that you weren't doing well enough to get the scores. You need to make sure your knowledge is really, really good in terms of knowing your guidelines. So consolidate your knowledge. You need to get lots and lots of practice. And you need to get feedback that's specific to you, and that feedback from someone that's willing to tell you what you need to change and what you're not doing well, not just what you're good at. It's nice to know what we're good at, but it doesn't help us to get better. Okay. So let's look at the habits of high performers. We've had quite a few doctors that have scored 90 plus and a few that have scored 100 plus, which is amazing. Puts you in the top sort of decile. Okay. And then I've interviewed some of them. I've asked some of them to give feedback as to how did they prepare. And I talked to someone this week, actually. The recording will be on our YouTube channel soon. Someone who went from failing to scoring over 100. So they didn't go from failing to just passing to smashing it and being in the top few percent. And so, talk to them about what did they change and what were the things that they did differently. And these are the things that are common in those that don't just pass, but do really well. The high performers, number one, they plan ahead and they start early on their preparation. So I would say 6 months before you plan to sit the exam, you should start reading some guidelines and maybe forming a study group and start doing a few cases here and there. 3 months before, you should be doing cases every week. Building up to the last month before, you want to be doing a couple of times a week that you're meeting, you're doing practice cases, and then make sure that you do some mini mocks or even a full mock where you actually get used to managing your time, doing it in exam conditions, doing cases back to back. Okay, so because there's a lot of things, right? There's a whole of general practice. I showed you the domains. The whole of general practice could come in the exam, right? So you want to make sure that your knowledge is airtight. Seek feedback wherever you can and have insight to take on board the feedback and make changes. Because again, in people that struggle, often they not only will they not actively seek feedback, when someone gives them feedback, they sort of have a closed posture and they'll try to make an excuse. Oh, I did that, you missed it. Oh, actually, I normally would do that. It was just that time. Rather than listening and thinking, okay, someone's identified something, I need to actually work on this and change it. So, you'll often see someone who has multiple fails. One of the things that happens is that they'll often have an external focus. So they will not look at what they can change. They will look at the external factors. There was noise, connection wasn't good, the exam's unfair, it's this, it's that. Now, there might have been noise. There could have been issues with connection, but there may also be things that you can change. So have insight and actively look to get feedback on what can I actually change. Develop good consulting habits in real life. Because it's not like you shouldn't be doing any acting in the exam. Leave the acting for the role players. They're getting paid for it. Okay. If you develop good consulting habits, then you just treat it like a normal clinic. The slight change being that it's done remotely, which is a bit different to how most of us do our normal clinics, right? Okay. But if you've got good consulting habits, i.e., you listen carefully, you're focused and concise in your history taking, you think about follow-up and safety netting, you manage your time well, you explain things in understandable language, you involve patients, you've developed good consulting habits, you're comfortable in your own skin, in your own consulting, then on the day of the exam, you're not suddenly trying to change anything or do anything for the exam. You just treat it like a clinic. And you've got good knowledge to back up And you just trust yourself to listen, to think about it, and do it live, and you'll be fine. You've got to, that brings me on to number 4, is that people that do really well, they really know their stuff. They've consolidated their knowledge base. They've read up their guidelines. They're up to date with how things are managed. They know that guidelines recently changed. They've got all of that so that they can confidently say to the patient, the research suggests this, or there's, 2 options in how we can manage this or this, or, and the patient believes them first time. They communicate effectively. They listen well. They explain things in understandable language. They don't use jargon or technical terms. They involve the patient in a person-centered way where appropriate. Work on time management. So people that are going to get great scores, generally, they're able to wrap up the bulk of their data gathering in about 6 minutes so that, they can spend a couple of minutes explaining the diagnosis and they leave themselves 4 minutes plus to deal with the management, because to discuss, maybe there might be more than one option of management, agree a management plan, talk about the normal follow-up, explain the risks and talk about safety netting. That's going to take a good 4 or 5 minutes. If you're still taking a history at 9, 10 minutes, by the time you've explained the diagnosis, the patient will leave, you're going to get no marks for management. And that has a big impact because that's weighted more. So working on time management in real life and by practicing cases to exactly 12 minutes. And then number 7, they will have actively spent time practicing lots and lots of cases across all 12 case domains so that they don't leave any gaps. Whereas some doctors, they will just rely on what they see in real life. And if you just rely on that, patients we see in real life, there can be lots of learning from that, but that might leave gaps. And that could be different for different people, partly based on factors to do with your surgery. I'll give you an example. If you're a male doctor and you work in a practice where there's 3 or 4 female GPs, some of whom specialize in women's health, it's likely that day to day, you just might not see a lot of the women's health issues because they know there's someone who specializes in this practice and they'll book in with them. But you're going to get a women's health case. So make sure you've actively practiced. Similarly, if you're a female GP registrar and you've got patients that come with men's health issues, they might prefer to see a male doctor about it. They might not, but they might. You see, if you just leave it to hoping I'll see erectile dysfunction or someone with prostate problems or someone with premature ejaculation, and they might not just come in. And so you want to actively practice some of these things where it might not be something that you see all the time. So you want to make sure you've practiced cases from all 12 case types. Okay. So let's talk about some useful resources, and then I'll take frequently asked questions, and I'll take questions from you guys, and then we'll wrap up. So, as a baseline, the official RCGP SCA pages, gives you authentic information on the format, the marking. They've got some sample cases, videos. It's definitely worth looking through all of that as a base. But then if you want additional, what they don't have is like cases that you can practice with mark schemes. They've got examples of videos and examples of what the information is. But as a start, if you want cases to practice, we've developed an SCA specific case bank. So there's 69 cases. They're in sets of 3 at a time. And we've done it this way so that if you're meeting with your study group, in an hour and a half, you should be able to get through 3 cases, i.e. 3 minutes to read, 12 minutes to do the case, then, time to go through feedback, and then you swap. And then you swap. So, all 3 of you have a go. And for each case, there's a sheet for the simulator that I'll show you. So on the eMedica page, all of our SCA stuff's here. Okay. So the SCA cases are here. And you've actually got details of what cases are covered. But there's also a chance for you to see a sample case. Okay. So if you click that, for each case, there's a sheet for the simulator, like a detailed script of what should they say, what cues to give, the answers to the questions about history, ideas, concerns, and expectations, how to behave. So, whoever's going to be the simulator, they should read all of that in detail before you start the case. There's a sheet for the doctor in the same format as the exam. And just like the real exam, some of them are shorter, some of them are longer, some of them have got images where appropriate. So you'd have a look at that and you'd have 3 minutes. You'd allow the simulator to read beforehand, okay? And then the most important one, each one has got a detailed mark scheme. And the mark schemes are in PDF format because sometimes people like to print this bit. So it's got instructions to give, what to look for. It's got the generic descriptors, but it's also got a specific mark scheme for data gathering and diagnosis for that particular case. This is what you're watching for if you're the examiner, and then you grade them for clinical management and complexity. It's specific and it's detailed for relating to others and interpersonal skills. And then there's what case domains did that cover? What are some of the key learning points and points for discussion, after you finish doing the case? But then you can also click the link to go to the relevant NICE guideline. So you can then read up about the topic and consolidate your learning. You see? So there's 69 cases. There's also 2 examples of consultations, full-length consultations that I've filmed with simulators showing examples of cases that will do really well, that are demonstrating good skills in each of the 3 domains. Okay. So there's 69 cases there, and that's the link for that. Then we've got our GP 100 case primer. So this was a full day course where we covered 100 GP cases and how to deal with them in terms of the data gathering, diagnosis, management, interpersonal skills. It comes with a 362-page PDF booklet with the teaching slides, and they're arranged in blocks of 5 cases. So these are recordings where I discuss, how would you approach the history from Parkinson's, the key things to ask for, red flags, how to do the examination, like how to do the pull test, actually show it. What's the current guidelines for management? How would you explain it in clear and understandable, and so on. Every 5th case is an interactive case. So there's a simulator, you see the audience asking questions. So while they're asking that, you can think, what would I want to ask? So there's over 8.5 hours worth of videos, and it includes a PDF course booklet. Okay. And all of these cases are covered. We have our MRCGP SCA Masterclass, which is 4.5 hours, a recorded course built into these sort of 5 modules. So there's some of what we've covered here, but in more detail in module 1. Module 2, those 25 feedback statements, they're covered in detail. What are the reasons people would get flagged for these different feedback statements? If you know what they are, you can learn how to avoid them. Okay, so they're broken down into the domains. Module 3 is about communication and consultation skills. So how to structure a good consultation. We teach you the CARE model. What tools do you need in your consulting toolbox? Okay, how to break bad news effectively, including a demonstration. The 3 C's of effective communication. Tips for remote consulting. So, when you're thinking about telephone consults and video consults. Then module 4 and 5, we have 6 interactive cases where we go through and discuss, and you'll see some of the doctors volunteered, and we've got people simulating the patients, and then I go through the key learning in terms of data gathering management for each of these cases. So we've got examples of different cases across domain, including a colleague case, and then we talk about tips on how to prepare, and then we have all of those and more in a bundle, our past CSA bundle, 12 months access to the GP 100 case grammar videos, 12 months access to the SCA Masterclass, so that's these videos, 12 months access to the 69 cases. We also, with the GP 100, you get the PDF of this, but within this bundle, you also get the printed version of that book, because some people just like to have it on paper, 362 pages. So all of that access for 12 months. If you were to get all of those separately, it would cost you over £650. The bundle is £495. It's you don't need any codes. It's automatically discounted. I'll just show you again on our homepage. So back to the eMedica page, SCA, past CSA bundles here. So you can see it is automatically there as a discount, but you can also pay for it in 3 installments if you prefer. So you'd pay the first installment now, and then automatically a month later, the second installment would go out. A month later, the last installment would go out. You get access 12 months to all of that. Okay. And then our most comprehensive preparation is our SCA Pass Plus bundle. Okay. So as well as everything that's in this, what you get on top of that is our full day intensive SCA course, where in that full day course, we have 20 cases role played by professional simulators. And everyone that has a participant space will have a go at an interactive case. So with a sort of, take part in part of the data gathering with a simulator, but then have one full mock case later on with detailed individual feedback. Exactly what do you need to change and work on? What are the things that, you did well, but more importantly, most of our focus on what are the things that you could improve if you want to get to a pass or clear pass standard. Okay, so it's a really interactive, very intensive day. So like 9:15 in the morning until like 6:35 in the evening. 20 cases done in a day, and we only have 12 participant spaces at each course. So it's a small group. Okay, we do have some observer spaces when the participant spaces are full, and we cover a lot of the high challenge cases. Because if you can learn to deal with the high challenge cases, the few medium cases you get, you'll walk those. Okay, so the Pass Plus includes everything in this, but then you also attend this, which is a live course, live via Zoom, and it includes 2 hours of one-to-one SCA coaching with our SCA coach. So you'll have, and we generally people book that like an hour, maybe a few weeks after coming to the course. So you've already had some feedback, work on that, have an hour, and then go away and work on the individual feedback, and then have another hour nearer the time of the exam for final preparation. And for each course, there'll be myself, another assessor, so Masuda or Anna, okay? And then we have a male simulator and a female simulator. So there's a very high sort of faculty ratio compared to how many candidates there are. Now, you can just book that full day intensive course without everything else in the bundle. Everyone that books the course gets access to this as pre-course learning and access to the 69 cases. But the full bundle also includes the GP 100 case crammer for a year, the book, and then the full day course and the 2 hours of SCA coaching. So again, if I just show you as the last thing before we do the questions, on the eMedica page, that's basically the top option here, okay? So we have limited spaces left. The next one is 3rd July. That's ideal for people planning to sit in either the September or October or November sitting, okay? So that you've got time after the course to make changes, but then also to book your one-to-one coaching session. You could just book the course if you want, without the one-to-one and without the printed book and without the GP 100. There are various options on there, okay, available. So before we do the Q&A, we will send you some links for further reading, some of the links I talked about, where you can access them. But the team will also post, do join. We have an SCA Facebook group, specifically for people who are actively preparing, but our more general GP training support group covers everything to do with GP training. So someone will post a link. But let me go through some of the frequently asked questions. And then if anyone's got any other questions, I'll take those after. So sometimes people ask, can I do the exam remotely? The answer to that is no. You can only do it in an approved GP surgery. Generally, it will be your GP surgery, but sometimes it might be a different practice in your area. Can I look things up? In real life, I was in clinic this morning. Sometimes I might have to check up. Like I had a patient, I had to look up the dose of, something like they had head lice. I haven't used treated head lice treatment for a long time. I know generally what it is I'm going to use, but the specific dosing. And so, I just wanted to double check it because generally we have that in children a lot. I know the dosing is slightly different. This was an adult with head lice and in a care setting. So it's slightly different. So anyway, like I'll often have nice CKS, GP notebook, and then I'll have the BNF online open, right? You can't have CKS or GP notebook or any other sites. Everything else is disabled when you're using the exam software. What you can do is you can have a paper BNF and paper BNFC, but nothing else. You couldn't have an Oxford handbook or any other guideline that you've printed off. You couldn't have anything else in the room with you. But a paper BNF and a paper BNFC, you're allowed in the exam, okay? Can I make notes during the consultation? Yes. So there's actually a system on the software if you want to make notes on screen, or you're allowed a whiteboard that has to be cleared or destroyed at the end. You can't keep any notes beyond the exam. And then sometimes people ask, can I sit the SCA before the AKT? Like, do I have to have passed AKT to be allowed? You can actually sit the SCA before, but that would mean delaying your AKT to ST3 because you cannot sit the SCA in ST2. You have to be in ST3. What most people do is try to get the AKT done in ST2, right? So that ST3, they only have to worry about SCA. And then once that's done, you've got other things to think about to get ready for CCT Avenue. Okay, so those are some of the really common questions. One more common question is people often ask, how many cases do I have to pass out of the 12? It doesn't work that way. You don't pass or fail cases in the SCA. Remember, you get scores for each domain. The weighting for the management domain is 50% extra. All that they do is add up your total score. If your total score is at the pass mark. So let's say the pass mark on your day 77. You score 77 or more, you pass. You score 76 or less on that day, you fail. That's it. There are no other options. There's only pass or fail, isn't there? Okay. So it's about your total score, not about individual cases. Okay. Right. So any other questions, please ask them in the Q&A, not in the chat. But just for those that haven't got questions, let me do the summary so that you can head off and we can finish on time. So remember, look, the SCA is a comprehensive and a challenging exam. The standard to get a pass for each domain is the standard for you to be suitable for independent practice, i.e., you don't need a supervisor anymore. What they're looking at is really all of the elements that make a great GP consultation. So you've got to be good at history taking. You've got to have good diagnostic skills. You've got to be able to solve the problem and put things together. You've got to be up to date in knowing how to manage things. You've got to be able to be safe. You've got to deal with complexity. You've got to have good interpersonal skills and relate to others well. You've got to be able to manage your time effectively because you get exactly 12 minutes and not more. What can be really helpful is to get honest feedback early and make changes and be willing to put the work in to consolidate your knowledge. And ultimately, what you want to do is, for the knowledge side, learn. And then for putting that into your consulting, practice. 3 different types of practice. So practice in real life, managing your time, picking up cues. Patients give us cues in real life. Practice explaining things in clear, understandable language. Practice being more focused in your history taking. Practice explaining diagnoses confidently, clearly, concisely. Practice explaining management and incorporating, the other person's ideas, concerns, expectations, involving them in the decision making where it's appropriate to do so. The next is practice that you do in a study group. Practicing in a group of 3, one being the doctor, one being the examiner, one being the simulator, and actually practicing things before you get there so you're prepared for them, practicing the things that you don't see that often or you don't feel confident in. Okay. And then lastly, practicing with feedback. You can do that with your trainer. You can do that whether you come to our course, the RCGP runner course, or you might have a local deanery course, but getting feedback on things that you need to change and on your consulting, not just on the communication, that's one aspect, but also on the clinical things. What can I do to make my history better, more focused? How can I make sure that my explanation's right, but that I'm actually up to date in my management? All of that together is going to get you to become someone who's great at consulting and that has got a great working knowledge. Because I leave you with this from Aristotle, because we are what we repeatedly do. Excellence, which is what we should all strive for, then is not an act, but a habit. If you do the work, you consolidate knowledge, you practice, you get comfortable in your consulting, you've become a great consultant with a great working knowledge of GP, and then you just trust yourself to consult like as if it's just a normal clinic and you'll be fine. The things that I did in clinic are the same things that I teach at the course. They're not made up for the exam. I try to practice what we teach, right? You have a good working knowledge, you put into practice those good habits, and then you'll be fine. You walk the exam. Okay. So really last thing to say is, I hope you found it helpful. Hope you've got a much clearer idea of the exam, of what to expect, why people might struggle, and what people can do to do really well, so that now you can actually do the work. And, myself, the whole team at Umedica, everyone at the MPS wishes you every success. Prepare and you will succeed. So thank you so much. For anyone that hasn't got questions, that's great. Thank you so much. Have a great rest of your evening. I will leave you to it. I'm going to stay back now and leave details of this on there. And I'll see that the team have dealt with a lot of questions. I'll try to deal with any others now. Someone said, any links for consultation skill structure to follow? So we cover the care structure, the care model, which we developed, have been teaching with great success for over a decade for people sitting the MRCGP, CSA, then RCA, and now SCA. We teach that as part of the SCA Masterclass, which is the pre-course learning for the full day course, or included in this bundle, or available separately. That's covered in detail, including examples on how to use it. Someone said, if they're just starting now for October, will it be enough time? It may be enough time. Everyone is different. Some people, they start now, we're halfway through June. You've got July, August, September, up to October. You've got just under 4 months because the first week of October is the exam. Depending on your existing level of knowledge and your existing consulting skills, that's a decent amount of time. Some people might need longer because they might not be able to put in so much time to practice because they've got a lot on. Everyone knows their own circumstances. But certainly, if you're thinking of sitting the exam in September or October and you haven't already started, you need to start now. I would recommend making a start now. But even better would be to start doing some consolidation of knowledge and some practice, I'd say 6 months before, and then ramp up as you get closer. You don't need to do intensive preparation for that amount of period, but starting 6 months before would be good. Okay, a couple of people have asked about our intensive course and the Pass Plus bundle. Yeah, so the only date available at the moment is the 3rd of July, but we will have courses. We generally run it once a month. So, we will have, once this one's full, we will set a date for a course in August and then one for September. Sometimes we don't have one in August, in which case there might be one right at the beginning of September, just in case a lot of team are on leave for summer holidays and so on. But this is ideal if you're thinking of sitting the exam September, October, November. The courses that we'll launch later, August, September, they're really for people sitting it in the January sitting onwards, okay? Because you want a good amount of time after the course because you're going to get detailed feedback on what you need to change to make those changes and to go away and practice. By the way, if you book the Pass the SCA bundle so that you can get started now with preparation, with all of this stuff, and then you decide later, because, we'll announce dates later for the SCA Pass. You decide, look, I'd like now change to this one, the Pass Plus, which includes everything in that, plus the full day course, plus the 2 hours one-to-one. You can upgrade by just paying the difference. So, you would have already paid 495. You can just pay the difference. Okay. Someone's asked just to explain what resources you can use during the exam. Only a paper copy of the BNF and a paper copy of the BNFC, nothing else. Okay. Someone said, is it better to book for the live course, then do 6 months? No, you don't need to wait 6 months after the live course, but you do want at least a couple of months, I'd say, after the live course to make changes. Because if we identify things in your consulting you need to change, you can't change something like that overnight. There might be knowledge things that you need to do. You might need some time to read that. But to change, let's say we identified the way you're doing this, you could do this in a better way, and we actually demonstrate examples of best practice. To then make that feel natural, you need to practice it a few times in real life or in role play settings. So, you want to allow ideally a couple of months at least after the course to make changes. That would be, but also if you're booking the Pass Plus, you want some time to have some of the one-to-one and make changes based on the further feedback you get at the one-to-one. Okay. Okay, great. So I can see that's the last question in the Q&A. Thank you very much for everyone that joined. Huge thank you to everyone in the eMedica team, for the faculty that answered questions, and the team that will process the recording and all of the rest. Okay. If anyone does have any other questions, feel free to email us, get in touch, you can send me a message. Okay. But I hope at least you have a much clearer idea of the exam, of how it's marked, of what to expect, of how to prepare. And now that you know that, go and do the work. Okay. You can actually make a start and get on with it. Okay. I do hope to see some of you at the intensive course, small groups, you get lots of feedback. Really nice to see people, after that they come back after the results and say that it made a change, not just to doing well in the exam, but often identifying things that can make a change to how they consult in real life. Okay, so that's really nice. Okay.